From the beautiful Finger Lakes region of upstate New York, this is the Dental Lighthouse Podcast. We take questions from anyone in the dental profession and discuss what it takes to win not only in dentistry, but in life. Business, leadership, relationships, parenting, health and wellness, money management, nothing is off limits on the Dental Lighthouse Podcast. I'm Jason Tenori, your host, and have over 20 years of experience to pull from. Learn from my mistakes and let me help you collapse time so you can become the best version of yourself. Yo, what's up? Dr. Jason here, Dental Lighthouse Podcast. Beautiful Thursday morning in upstate New York in the Finger Lakes area. I'm actually in Canandaigua today. And something that's been relevant with my group coaching and a couple of one-on-ones this week. So usually when I see patterns develop over a few sessions with my coaching clients, I feel like it's important enough to bring to you guys. So the issue here is this territorialness of associate doctors with patients, right? And before you're like, oh, I have to deal with that problem too, it's always good to take a step back and gain some perspective, right? My good friend Mark Hostis calls this the success tax. My coach and mentor, Alistair McDonald, calls this a ceiling of complexity. Right. So these are problems that you wish you had 5 years ago, 10 years ago. And your success has come with a lot of awesome qualities, but it also comes with a set of headaches that you have to solve for. And this is one of them. So in a nutshell, we're talking about some doctors who have multiple associates, 3, 4, 5 associates in their practice. And now we're starting to run into the issue of, do we force patients to stay with specific doctors? Let's call it an associate-centric model versus are we a patient-centric model where we have some systems in place to make sure that we're being flexible with patient scheduling and who sees who and stuff like that. And before I kind of dive into both of those, the reality is there's no wrong answer, right? There's just what the owner, founder, visionary has decided on what they want their practice philosophy to be. Do they want it to be patient-centric or do they want it to be associate-centric? So let's talk a little bit about both. In my particular world, we believe in patient-centric strategy. So what exactly does that mean in a granular tactical way? It means that when a treatment plan is developed, either out of hygiene or even a new patient on the doctor side, new patient in hygiene, we have a decision to make on who's going to do that treatment. If it's something straightforward, few fillings, crown, basic endo, we fill out the router, develop a diagnosis, develop a treatment plan. And when the treatment coordinator either comes back and talks to the patient in the room, or if we present treatment at the front desk, if it's a basic treatment plan, our verbiage is, would you like to stay with Dr. Smith, who is who you saw today? Or would you like the first available appointment for this dentistry? And that's a patient-centric philosophy because the patient is choosing if they liked Dr. Smith or not, right? That's an indirect way of saying, did you like the doctor that you saw today? So that's the first thing. We're giving the patient an out by not forcing the patient to admit that they didn't like that particular doctor. And then the second thing is we're being super cognizant of the patient's schedule, right? And this is not an old school mentality. You know, it used to be, even when I started, this mindset still existed of, I'm the doctor, you're the patient, you're going to come in when I say, you're going to do what I say to do. You know, that ship has sailed, right? And we're in a service-based industry. And if we're trying to serve the patient to the highest level, I truly believe that you need to have a patient-centric philosophy. So patient gets to the front desk and says, okay, I'd like to get this crown done. Okay, TC, would you like to stay with Dr. Smith or would you like the first available appointment for your schedule? And whatever the patient answers, that's what the TC or scheduling coordinator will ultimately do. Now, there's situations where the doctor that diagnosed it doesn't work on specific days, and those are the best days for the patient. There's a lot of reasons why the patient would choose an appointment or a doctor that's not the diagnostic doctor, and it is what it is. So that's what we do. Before we go to the associate centric model, I want to just touch on a few things. If you're going to have a patient centric model, you must be calibrated on diagnosis and treatment plan. There is nothing worse than Dr. X making a diagnosis and treatment plan of a patient, and then the patient gets to the front desk, and because of their schedule, they decide to schedule the treatment with Dr. Y. It ends up in Dr. Y's schedule, and Dr. Y looks at the diagnosis and treatment plan and doesn't agree. And not that Dr. Y is right or wrong, but if they simply don't agree with the diagnosis and treatment plan, now there's an uncomfortableness. Now they have to decide, am I going to move forward with this diagnosis and treatment plan, or am I going to pivot while I have the patient in the chair and undermine trust that has been developed by this patient or by the practice to this patient? And it leads to a lot of ambiguity, a lot of misunderstanding. So that's why it's so important to be calibrated. And what do I mean by calibrated? Having constant conversations, having a calibration document. Be more than happy to send you guys mine. If you're lacking it, it's only 160 pages of lots of stuff. But being calibrated, right? So when do we do a filling? When do we do a crown? When do we suggest endo is possible? When do we suggest endo is probable? All of these things. So that's part of it. The other part of it being patient centric is if the doctor has enough self awareness when they're diagnosing and treatment planning a situation where the treatment is considered, let's call it heroic, right? So what do we mean by that? We mean maybe a compromised tooth where we should be taking it out and putting an implant in, but the patient really, 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 really wants us to try to do endo buildup crown. The diagnostic doctor has gone over all the positives and negatives, has had a real intimate conversation with the patient. If the treatment plan is that level of, again, we'll call it heroic dentistry or just non-standard dentistry, then on the router, we must put that this treatment has to stay with this particular doctor. Because again, nothing is more worse. I just created a situation a few seconds ago where a fairly straightforward treatment plan is not agreed on by the doctors. That's not good. But nothing is worse when the diagnostic and treatment planning doctor agrees to a heroic treatment plan. Again, in this example, let's keep it simple. A tooth that should be extracted, but the patient absolutely refuses. So the doctor agrees to endo buildup crown, tells the patient this thing's only going to last 3 years. Patient's excited that they're being heard and that they're being listened to, and they get it scheduled. Nothing's worse than having that conversation with the patient in hygiene or at a new patient exam, and then having another doctor see that treatment, right? It's unfair to the other doctor. It's unfair to the patient because now they have to re-explain themselves. So that is the one situation where we insist that the patient stays with the treatment planning doctor. Now, if it's not clearly articulated on the router, then how does the treatment coordinator or the scheduling coordinator, whatever you're calling your unicorns at the front desk, how do they know that? Right. So you have to have a system in place that is allowing for that heroic dentistry to stay with the same provider. So that's that's a summary of the patient-centric model, right? What's the associate-centric model? Well, the associate-centric model is I diagnose this, I treatment planned it, I should do it, right? That patient belongs to me. That treatment plan belongs to me. And again, no judgment, nothing wrong with that, but there's some inherent issues with that. But there's some positives too. So, what are the positives? Well, the primary positive is you avoid having to deal with the calibration issue, right? So, if the diagnostic and treatment planning doctor is ultimately the one that will do the treatment, then you don't have to worry about other doctors in your group making sure that you're calibrated and the treatment plan philosophy is the same. Now, you still should be calibrated, but it's not nearly as important. That's the first thing. The second thing is it allows the doctor to, eat what they kill, for lack of a better term, right? So the doctor knows that the associate knows that, okay, I diagnose this, I treatment plan this, I'm going to get the ability to do the procedure, and I'm going to be compensated for this procedure. Again, that's business 101, right? That's capitalism. What are some disadvantages of that? Well, one of the primary disadvantages is the patient is locked in to that particular doctor's schedule. So if that doctor works Monday, Tuesday, Wednesday, and the patient really wants to have this procedure done on a Friday so they can have the weekend to recover, then they don't have that option, right? So that's not, in my opinion, that's not fair to the patient. Another disadvantage of the associate-centric model is, what if the patient doesn't really like the doctor, right? If it's a solo practice, then the patient can just go to another office. But it's a huge inconvenience and pain in the ass for the patient to transfer offices. If they liked the office, they just didn't jive with the patient. I'm sorry, with the provider. So having an associate-centric model where you're insisting that the patient stays with that particular provider is not good from a patient satisfaction perspective. The other thing that it really does, having an associate-centric model, is it just creates this philosophy of, and this is not even a word, but of territorialism, right? These are mine, those are yours, like stay in your lane, right? It's not a team effort. It's not a let's build this thing together. It's not a let's try to like knock the socks off of all of our patients and everybody do their part, right? It's very territorial. It's very scarcity mindset. So why would associates have this mindset? Well, primarily it's because they fear of not being busy enough, right? And associates by default, when their schedule is not busy enough, are going to automatically go to, hey, why is the other doctor seeing that patient? I'm the one that treatment planned it. I'm the one that diagnosed it. I'm the one that should be providing that care. So if that's the mindset because their schedule is open or because you have associates with open schedules, then let's look at what else it could be. The first thing that we need to look at is how many at-bats are we giving our associates, right? Or how many exams are they doing on a regular basis? Everybody's going to be a little bit different here, but if I have a full-time associate in our group, I want them to have 35 to 40 new patients per month. And that's a 4-day a week full-time associate, right? So we use weekly scorecards. I hope you do too. So roughly 10 new patients per full-time associate per week. And by new patient, we mean any type of new patient to the practice. We mean comprehensive new patient exam, consult, limited, it doesn't matter, right? And again, I'm not suggesting that these metrics have to be ones that you follow. You do you, but this is what's worked for us. So whatever you decide on your number, if in reviewing weekly scorecards, your doctors are not consistently getting to that number, that's a you issue. That's a leadership issue. That means you either don't have enough patient demand. You might have to look at your marketing operating system. And again, by marketing operating system, I don't mean pour more money into marketing. I mean, are we answering the phone? Are we converting new patient leads? Is our schedule set up in a way where a new patient can get into the doctor's schedule or hygiene schedule within the next 2 weeks? These are things that you need to be looking at. What's another reason the associates might have an open schedule so they become territorial with their treatment plans? What if their case acceptance is low, right? So the associate has a 20% case acceptance, which is leading to an open schedule, right? So the associate wants to blame the fact that the dentistry that they propose is with another provider, but the real issue is that the associate has a very low case acceptance. Now, why is that? Again, could be any number of reasons. Could be that the associate is presenting too many treatment plans. Could be that the associate is condescending and not an empathetic listener. Could be that the associate was condescending. It's a lot of, it could be a lot of reasons, right? So figure out a way to get the case acceptance higher, and then all of a sudden the associate's schedule stays busier. Now, what does higher mean? In our particular group, we strive for a minimum of 35% case acceptance. But that doesn't mean if your associate's at 20, you need to get them to 35. If they're at 20, you need to get them to 25. If they're at 25, you need to get them to 30. And that is done through mentorship. It is done through observing exams. It is done through role playing. It is done through recording the associate's case presentation, hygiene exam, and watching it with your associate and collapsing time for them and giving them resources as to you should have did that, you should have did this here, you should have done that there, and helping them become more fluent in that conversation and with their case acceptance and their case presentation. It also, and this is a podcast for another day, it also has to deal with how you're presenting fees at the front, or if your TC comes back to the operatory. Are we just offering cash discounts, or do we have quote unquote flexible payment options? We've talked about that in the past, and that also helps case acceptance. And then the final thing I'll touch on with why associates can get territorial. Again, they get territorial because their schedule's open, but what's another reason? Again, they're either not seeing enough exams, they're either not closing enough cases, or they're not presenting enough treatment. So again, if your case acceptance is 20%, then you need to present roughly 5 times the dentistry that you need to achieve your goal. Let's look at it a different way. If your associate's goal is to do $100,000 in a month, but their case acceptance is only 20%, that means that in the previous month or two, they would have had to present $500,000 worth of dentistry. That's not a good number. That's not a bad number. It's a number. But if your associate expects to do 100,000 and their case acceptance is at 20%, and you look back in the previous 4 weeks to see what they've actually treatment planned, and it's only 200,000, we have a data issue. So we either need to increase the number of treatment planned dollars, or we need to increase the case acceptance. It's just math, right? I find that too often dentists don't know the math. So you can't solve for these problems without knowing the data. So those are the two philosophies, right? Patient-centric versus associate-centric. And if you have associates that are associate-centric, I think it's a symptom of a deeper rooted issue, either not enough exams, not enough new patients, not enough case acceptance, not enough treatment presented. So I'm advising doctors to decide what their philosophy is and then solve for that. One final point I want to make is sometimes there's a hybrid that you can do here, right? So and I don't do this in our offices, but going from a completely associate-centric model to a patient-centric model overnight can be a heavy lift. So what is a way that you could transition? Well, you could come up with a timeline of when this treatment is proposed. It must stay with the doctor if the patient chooses to schedule for the next 3 months, 6 months, 9 months, 12 months. Again, you decide. So what are we saying here? We're saying that when Dr. Jones goes into the hygiene room and presents a crown for Mrs. Smith, that treatment plan and treatment needs to stay with Dr. Jones for at least 3 months, for at least 6 months. So if the patient gets to the front desk and is ready to schedule, it stays with Dr. Jones. Dr. Smith, sorry. If the patient's not ready to schedule and they call 2 months later, 3 months later, it still stays with that doctor, right? But based on the agreed upon timeline that you guys come up with. Again, could be 3 months, could be 6 months, could be a year. But what you're not going to do is when an associate presents a treatment plan, patient says they'll think about it. They go through 3 or 4 hygiene cycles or recall cycles. And then 3 or 4 years later, they're ready to move forward with treatment. Like, it doesn't automatically go to that first doctor that diagnosed it and treatment planned it. It makes no sense, right? So if your associate has that mindset, it's time for an uncomfortable conversation. But if you have that associate-centric model and you're looking to transition to a patient-centric model, a safe way to do it is to come up with a timeline. I would say 6 months, right? So as you transition to a patient-centric model, you tell your associates, this is the direction that we're heading in. And for the foreseeable future, if you diagnose and treatment plan something, I'm insisting that the front desk keeps it with you as the diagnostic and treatment planning doctor for 6 months. So if the patient wants to schedule right away, it's with you. If the patient calls back a month later, it's with you. If the patient calls back 3 months later, it's with you. If the patient calls back 9 months later and is ready to do the treatment, then we go right into the patient-centric verbiage. Would you like to stay with Dr. Smith, who originally diagnosed this, or would you like the first available appointment to have this dentistry done? Again, not right or wrong, but that's what we do because we're a patient-centric office. We're constantly putting it on the patient and giving them the opportunity to schedule with who they want and when they want. So I hope this helps, guys. If you're dealing with this success tax, with this ceiling of complexity, I hope this helps you. If you have questions about this, or if you want to get more specific with a system to develop to fix this, reach out. My contact information is on our website, thedentallighthouse.com. You can email me, you can text me, and I'll walk you through it a little bit more. Appreciate you guys listening, and have an amazing day.
Thank you. That wraps up another episode of the Dental Lighthouse podcast. You have a choice today. Choose to be a lighthouse. Lighthouses are powerful and steadfast. They are beacons of light for others to reference when life gets turbulent. Go out into the world today and become a lighthouse for someone. Give more than you get. True joy comes from serving others. Start today. I'm Jason Tenori, your host. Thank you for listening to the Dental Lighthouse podcast. For more information, podcast show notes, or links to anything that we have discussed today, please check out our website, thedentallighthouse.com. We would love to hear from you. If you would like to get on the show, please email us at podcast@thedentallighthouse.com.